Let us now talk about the pathophysiology. In case of pathophysiology, remember, many students fail to understand this fact that they have to mention pathophysiology in their exams, especially university exams. It carries a lot of marks. So, talking about the pathophysiology here, I have simplified it with the help of this table. There might be multiple etiologies for uh, one single mechanism or multiple mechanisms. Different mechanisms also may have same etiology. So, you have to understand this point here. So, reduced ventricular contractility. Whenever contractility of the ventricle is reduced, the pumping capacity of the heart is reduced. Example here is myocardial infarction because of coronary artery disease. That particular part of the heart is become dead. It's not contracting. So this is segmental dysfunction. Sometimes the whole myocardium is not working. Global dysfunction we call it. Then we talk about the ventricular outflow obstruction. The outflow of the ventricle has got obstruction in the form of aortic stenosis, hypertension, all right, or HOCM, all right. Then we have got ventricular inflow obstruction. Ventricular inflow obstruction, wherein blood is unable to reach into the ventricular as a result of pulmonary hypertension, pulmonary valve stenosis, especially in the right heart failure settings. Now talking about the ventricular volume overload. If you talk about the ventricular volume overload, especially in mitral stenosis, tricuspid stenosis, left ventricular volume overload is seen. Whereas ventricular septal defect is also an example of ventricular volume overload because of the left to right shunt. Then we have got right ventricular volume overload, especially in the atrial septal defect. Then we have got increased metabolic demand or high output failure we call it in cases like anemia, thyrotoxicosis, beriberi, arteriovenous shunts. All these are increased metabolic demand kind of failures. Talking about the arrhythmias, especially atrial fibrillation. So chronic AF can precipitate heart failure. One of the common causes of arrhythmias which cause heart failure is atrial fibrillation, atrial tachycardia, and complete heart block also precipitates heart failure. But it's an emergency to deal with. Then we talk about diastolic dysfunction mechanism. How does diastolic dysfunction occur? Because of diastole is the heart relaxes, is it not? During diastole the heart is relaxing. So if there is obstruction to the relaxation part of the heart, that is from outside there is some constriction, so constrictive pericarditis or restrictive cardiomyopathy, left ventricular hypertrophy along with fibrosis, I told you, endomyocardial elastofibrosis, I told you, then cardiac tamponade. All these conditions will cause diastolic dysfunction. So these are the pathophysiologies of heart failure. So this is the pathway which I was talking about. If you understand this pathway, you will understand the management. It's very, very simple. So heart failure begins with baroreceptor dysfunction. So we have got baroreceptors present over the carotid bodies, the chemoreceptors and the baroreceptors. Here baroreceptors, the pressure sensing receptors, are becoming dysfunctional. This signals an afferent inhibitory signal to the brain. What does brain do? Brain's vasomotor center responses to this parameter by either by increased sympathetic tone or by increased vasopressin. All right. So here if you see, increased sympathetic activity or increased vasopressin response will result in decreased renal blood flow, increased aldosterone, hyperaldosteronemia, then increased sodium absorption, reabsorption, and water reabsorption. Sodium water reabsorption occurs as a result of hyperaldosteronism. So all these are because of this baroreceptor dysfunction. Now, increased sympathetic nervous system activity can also result in decreased limb blood flow. So increased sympathetic activity will try to because of vasoconstriction, what happens is peripheral vasoconstriction occurs and there is a decreased limb blood flow. Now talking about the response of the kidneys, there is hyperreninemia, increased renin secretion, and increased activity of angiotensin 2. This also, now this pathway, what are you calling it? This pathway you are calling it as RAAS pathway, that is renin angiotensin aldosterone pathway. This has to be blocked by one pharmacological agent. Vasomotor response has to be blocked. Vasopressin has to be blocked. Sympathetic nervous system has to be blocked by giving beta blockers. Baroreceptor dysfunction should be corrected. Sometimes you should give some blockers to the vasomotor cortex also. So one after the other, we'll try to understand what are the management features, but this is all about the pathophysiology. Now let us talk about the mechanisms that cause changes in the ventricular musculature. We call it ventricular remodeling. So why does ventricular remodeling occur? Because number one, because of myocyte biology changes. So what happens is there is a fetal gene expression, beta myosin heavy chain, beta adrenergic receptor, that is beta blocker, desensitization of the adrenergic response, myocyte hypertrophy, impaired cytoskeletal proteins, and abnormal excitation contraction coupling. All these are myocyte biology parameters which are changed. So myocardial makeup or architecture change occurs because of necrosis, apoptosis, autophagy, interstitial and perivascular fibrosis, and matrix degradation. For your exam, you can remember one or two of these. You cannot write entire list, but please mention ventricular remodeling mechanism. This is also very important to mention in your exam to get full marks in your long question especially. Then we talk about the changes in the ventricular geometry. Here especially we see the ventricular dilation and wall thinning. Then arterioventricular valve regurgitation and increased sphericity and displacement of papillary muscles. Now we have come to clinical features, understanding of clinical presentation of heart failure. In this, we'll discuss with the help of this diagram. So there is a raised JVP, pulmonary edema, cardiomegaly, pleural effusions, bilateral pleural effusions which are transudate in nature, then pitting type of edema which is very much significant. These are all the features that point towards the left heart failure. I told you this classification is obsolete, but clinically to understand which side of the heart is affected first, you can easily understand with the help of these symptoms. Talking about the symptoms of raised JVP, hepatomegaly, ascites. If you don't see any pulmonary edema, cardiomegaly, simply you see hepatomegaly, ascites. Abdominal features are very, very common. Pitting type of edema is very, very common and more marked. And patient is telling you that there is a pitting edema followed by ascites, followed by hepatomegaly, and then shortness of breath. Then your diagnosis should be right heart failure. So to quickly revise, now this figure will also help us to understand left-sided heart failure versus right-sided heart failure, wherein patient usually presents with restlessness, confusion in left-sided heart failure, orthopnea, tachycardia, exertional dyspnea. You can see he is lifting a dumbbell, so there is an exercise intolerance, fatigue, and cyanosis, bluish discoloration, peripheral cyanosis seen. So bluish discoloration of the lips and fingers and toes and all. Patient also has got elevated JVP. More importantly, patient has got paroxysmal nocturnal dyspnea, elevated pulmonary capillary wedge pressure. Pulmonary congestion is seen in the form of cough. On examination, crackles are seen. Wheeze may also be present. Blood tinged sputum is also seen, and tachypnea is there. Now talking about the right heart failure. The right heart failure, usually the patient presents to you with fatigue, increased peripheral venous pressure, ascites, enlarged liver and spleen, hepatosplenomegaly. Patient may be a secondary case of COPD, chronic obstructive pulmonary disease, or sometimes there is a distended jugular vein which is seen. Anorexia is an important complaint. Weight gain is also an important complaint, and dependent edema is also an important complaint. So don't say pedal edema always, say dependent edema, because patients usually may be bedridden also. In a bedridden patient or in a neonate, in an infant, heart failure is diagnosed by profuse sweating and sacral edema, pre-sacral edema we call it. So apart from this, there is an important classification that is asked for you in your MBBS final exams. Practicals also they will ask you NYHA classification. Definitely every alternate student they'll ask in a short case. So NYHA classification, you have got class 1, class 2, class 3 and class 4. New York Heart Association functional classification. For shortness of breath, we have got class 1 is no limitation of physical activity, and ordinary physical activity does not cause any fatigue or dyspnea, palpitation, angina or symptoms. Class 2 is slight limitation of physical activity. Patient is comfortable at rest, but on ordinary physical activity like carrying heavy package or lifting heavy weight, this may result in fatigue, dyspnea, palpitations and angina. Class 3 is there is a marked limitation of physical activity, wherein the patient is comfortable at rest, but less than ordinary physical activity if he is doing, getting dressed or talking for a long time, it leads to symptoms. Next comes the class 4, wherein patient has got severe limitation of physical activity and there is the symptoms of heart failure, angina are present even at rest. So at rest symptom is class 4, less than ordinary activity is class 3, symptoms at ordinary physical activity is class 2, and no limitation of physical activity and no symptoms or ordinary physical activity is not causing any symptoms, it is class 1. There are 4 classes of NYHA classification. This criteria has become obsolete because it is not mentioned in most of the textbooks, but still sometimes your examiner is very fond of asking and they want to see this criteria written in your MBBS exams, university exams. So we'll talk about this criteria for diagnosis of heart failure, that is Framingham's diagnostic criteria we call it. Framingham's diagnostic criteria is divided into major and minor. Major criteria includes acute pulmonary edema, cardiomegaly, hepatojugular reflex, jugular venous or neck vein distension, paroxysmal nocturnal dyspnea or orthopnea, rales or crepitations, third heart sound, that is gallop type of third heart sound. These are all the major criteria. In this, one is the diagnosis, pulmonary edema. Pulmonary edema is diagnosed by what? Pulmonary edema is diagnosed by orthopnea and rales, that is bibasal rales, alright. So apart from this, one is auscultatory finding, that is third heart sound. All others are general physical examination findings. One is the symptom with which the patient presents to you, that is orthopnea and PND. So one symptom, one different physical examination, general physical examination, auscultatory findings, and then one diagnosis include major criteria. In case of minor criteria, symptoms like ankle edema, dyspnea on exertion, hepatomegaly as a clinical finding. This is not a symptom, it's a clinical finding. You find it, you do examination, you find it. Nocturnal cough, pleural effusion, and tachycardia more than 120 beats per minute considered as minor criteria. When do you diagnose heart failure? According to Framingham criteria, heart failure is diagnosed as when there are 2 major criteria or 1 major plus 2 minor criteria. So either 2 major criteria or 1 major plus 2 minor criteria, you diagnose heart failure. Next we talk about what are the precipitating factors of heart failure. Now, this is optional to write in your exam. You need not write also. Sometimes examiner is fond of asking questions. Sometimes you will get a short note. Write the precipitating factors of heart failure, etiology of heart failure, something like that. So in that you can write patient related factors like emotional stress can precipitate heart failure, excessive sodium intake, heavy alcohol use. Next is provider related. That is, as a doctor you are giving a lot of NSAIDs, other medications which is causing salt and water restriction. If the patient is using some negative inotropic drugs like calcium channel blockers, there is a very bad habit of many doctors starting calcium channel blockers to young people who present to you with hypertension. Remember, who presents to any patient who presents to you with hypertension for the first time, young person without any comorbidities, essential hypertension when you are diagnosing, please don't start calcium channel blockers. Please start ARBs with or without a diuretic. So ARB or AC inhibitor with or without a diuretic, you have to start. Then you can consider adding it with other agents. Then last to consider is calcium channel blockers. But if you start with calcium channel blockers in a young person, then get ready to face heart failure in this case 10 years down the line or 15 years down the line. Next comes unrecognized congestion and inadequate use of diuretics. Most of the times what happens is diuretics is troublesome to use. You start a diuretic for a hypertension case, and because of the various side effects, like some diuretics cause hyperuricemia, some diuretics cause fatigue because of loss of electrolyte, some diuretics cause body pains. So patient usually cuts the dose by himself, and sometimes non-compliance is seen. For such cases also suddenly it may precipitate heart failure. Next is heart failure, that is heart related precipitating factors like uncontrolled or poorly controlled hypertension, myocardial ischemia, arrhythmias, especially atrial fibrillation, pulmonary embolism. Other diseases which can precipitate heart failure are systemic infections. Patient is in sepsis, can present to you with cardiogenic symptoms or cardiac failure later on. Then worsening renal or hepatic failure, hyperthyroidism, anemia, untreated sleep apnea. So all these are important causes of precipitating factors of heart failure. How do you define cardiac cachexia? What is cardiac cachexia? Usually what happens is because of a prolonged cardiac illness, the patient develops certain physical body features of decreased muscle strength or fatigue or anorexia, and body parameters are changed, that is cardiac cachexia. So how do you define cardiac cachexia? It is edema free weight loss of at least 5% in 12 months or less than the presence of underlying illness, BMI less than 20 kg per meter square, and at least 3 of the following criteria: decreased muscle strength, fatigue, and anorexia. Low fat-free BMI, that is lean tissue depletion by DEXA. How do you know that BMI is, whatever BMI is contributed by fat or muscle or bone? You should do a DEXA scan. So DEXA scan less than 5.45 in women and less than 7.25 in men is diagnosed as low fat-free BMI. And this is one of the features of definition of cardiac cachexia. Next comes the abnormal biochemistry, wherein you will have to do CRP levels more than 5, IL-6 levels. Nowadays we are doing serum IL-6 levels to diagnose heart conditions and inflammatory conditions. More than 4 picograms per ml is also an indicator of cardiac cachexia, apart from hemoglobin less than 12 and albumin less than 3.2. Cardiac cachexia again is an optional thing. You need not write in exam. Only an extra short note or a very short note comes to you, or examiner particularly asks you about that, then only you mention in the exam. Now